to share, my learnings and also practices within my division at the Department of Public Health, but also at the same time, this opportunity to really be with colleagues, who are very much passionate about the work around like quality improvement, especially with a race equity lens. So let me share my screen right now. Today's presentation, and then later on, we'll have some Q&A and discussion, is really around taking meaningful steps to narrow racial health gaps in behavioral health and leveraging racial or cultural match and access data stories from my department. And with behavioral health, I belong to the Child, Youth, and Family System of Care, as Marie has mentioned a while back. So I will share experiences from that division per se. But before we really delve into what the work was and how it had an impact in terms of action steps we took as a division or as a department, let me first share what really anchors our work around like QI within our division of the Children, Youth, and Family System of Care. And these are really, in terms of anchoring, these are really our system values and our existing practices that we have implemented and disseminated for quite some time now. And we use that as our anchor in terms of really thinking through our QI projects or quality improvement efforts within our division. So I call them usually like pillars in the use of like QI tools. And at the center of that is really looking at like race equity. Our department primarily ensures that San Francisco residents achieve their best health, specifically their best behavioral health, eliminating racial and ethnic disparities. And within our department, we have a separate office of equity and workforce development that is really our hub that organizes and coordinates all our efforts around race equity. Also in thinking about the population we serve. So within my division, the Children, Youth, and Family System of Care, we serve primarily Black, Indigenous, people of color communities. Around 35% of the clients and families that we serve identify as Latina, Latino, Latinx, or Latina, or Hispanic. And then about 20% identify as Black or African American, and about like 13 to 15%, depending on the time, identify as AAPI or Asian American Pacific Islander. So you could see like most of the people that we serve within our system itself are really Black, Indigenous, people of color. So having a race equity lens is indispensable, and it's really much needed in terms of how we implement or disseminate our work. At the same time, something that has been strong in our department as well since 2014 was a trauma-informed system, wherein we use principles of trauma-informed care to really facilitate a holding environment for doing treatment, intervention, and also assessments of the clients that we serve. And this entails like upholding and strengthening principles such as understanding trauma within the clients that we serve or populations that we serve, maintaining safety and stability or helping our clients reach a place of stabilization or stability in their life and in their families, approaching the work with cultural humility, and also collaborating with our clients in terms of really recognizing that treatment, although it seems at first to be a hierarchical model, we have to adopt a more collaborative model in the way we implement or we intervene with our clients around mental health or behavioral health. And part of it too is recognizing with our work as like clinicians, we recognize that through the years, there has been a paradigm shift in terms of thinking about the relationship between a clinician and clients. When before, really the sole expertise comes from the clinician or the provider of a service, now we see it more as a collaborative effort wherein you empower clients to be their own authors of their story around recovery and intervention. In such a way, it becomes collaborative. So for example, one of the models that we use around assessment is a collaborative therapeutic assessment model, whereby it's not about having a tool that you just give to a client and they address it, and it's very hierarchical in terms of facilitating it, but really assessing clients in terms of their story of what brought them to treatment through a more collaborative effort and more a storytelling effort around it. So it's more collaborative that way. Other pillars in our use of QI tools really come from expertise or competence that we are strengthening in our division around the use of QI tools. I think it was around 2015 when we had a QI Academy. And from there, we learned a lot of tools around like Lean and Six Sigma on how to really have more pragmatic steps in how we hold our QI efforts within our department. At the same time, when we think about Lean, a lot of these tools as well talk about like data and doing data analytics. At the same time, in the work of clinicians, we also think about how we approach answering the question, how effective is our work, by looking into evaluation and research efforts. Now, when we think about research or evaluation, there's a lot of Western-based models there of facilitating research and evaluation. But at the same time, within our division, we have to take a pause in terms of really recognizing that a lot of those tools might not easily translate, and they may not be culturally responsive to the populations that we serve. So this encouraged us or motivated us to really look into other models of thinking about research and evaluation in terms of indigenous tools, or models that are more collaborative rather than hierarchical in terms of like participatory community-based research or evaluations. So for example, in thinking about indigenous research methods, there's this one lean tool around mapping your process of doing, for example, clinical intervention. And we could use like a swim lane process map, and then changing that to make it more indigenized. Sometimes we try to adopt like metaphors that are alive within certain cultures that we serve. So for example, the use of a journey stick, which derives from Native American or Aboriginal cultures as a way to metaphorically represent one's journey through a process. So instead of calling it a swim lane process map, we call it like a journey stick of our process around, for example, a clinical intervention. So using models like that, which really comes from indigenous research methodologies or indigenous ways of really facilitating storytelling around data, are some things we have integrated within our system. And within our system too, like within the past, I would say 10 to 20 years, there has been a shift in terms of looking at data analytics, in terms of refocusing the work from just looking at numbers to really looking at data as a vehicle for storytelling. So now there's a big push around how do you visualize your data in such a way it tells a story. And when the people see that, they could relate to it by really aligning it with stories in their life. So engagement happens in a storytelling fashion. So within our system, in the CYF division that I mentioned, since 2015, we created an infrastructure and initiative around data reflection, where we reflect on our data in a collaborative way, but also using a storytelling mechanism by which we facilitate storytelling around our data. Let me move to the next slide. So just to orient us a little bit, within DPH, this is just sort of like a map of our different services or different divisions. And the one where I came from is really from the Children, Youth, and Family System of Care, which is really one division in our Behavioral Health Services division. And the others are AOA, or the adult, older adult, and the TAY. And then we also have our separate substance use services for children and adults. And so what I'm going to speak more today is really QI efforts that we have done within the Children, Youth, and Family System of Care. Now, the next question I wanted to address here is, how did we adopt or adapt our QI practices leading to QI improvement efforts with a race equity lens? Just to mention that there are so many race equity data and QI tools out there and processes that have been developed across the US and around the world that really talk about a racial equity data roadmap, or things you could do with your QI efforts wherein you would hold really a race equity lens. Now, one that I have adopted and adapted in our own division is really coming from the Massachusetts Department of Public Health around a racial equity data roadmap. And the reason why me and my team really like this, it's because it's very pragmatic, and it also tells a story of really a journey, like going down the road. And it was also something that it was easy to engage in with a lot of providers in our system that may not be QI involved. They are clinicians or providers of mental health services, but it was a way for them to truly understand QI in a way that they could really access and engage better in it. So using this racial equity data roadmap, we try to follow some of the recommendations here. And again, this is not a one-size-fits-all approach. And even the ones who developed this mentioned that it is not a toolkit, but it's really like a template that you could flexibly approach to in your work around QI within your own department. And really, like similar to other journeys, sometimes we have detours, and that's okay. As long as you maintain like principles of the work, it is also something that you could tailor fit it better for your organization. So based on this racial equity data roadmap, and I will walk you through some of the steps that we used along our QI improvement efforts and how we have maintained some of the principles from this roadmap. is now going to answer the question, how do we identify first our improvement project? So as I mentioned a while back, within our division, the Behavioral Health Services, we have a separate office that really holds, that is the holding environment for all our race equity efforts. And that's the BHS Office of Equity and Workforce Development. And for the past 2 years, this office has developed like a racial equity plan. And that has been actually systematized and structured through learnings from Lean. And from there, they created an A3, which really holds most of our race equity plans for the next 3 to 5 years or even 10 years. And I'm not expecting you to, of course, to read the small print on that because it's, I just captured the A3 in its entirety. But something that I would want to zoom in is really like the problem statement. The problem statement that has been identified by our BHS Office of Equity was around our workforce. Our behavioral health service workforce does not adequately represent clients served. Example, there's a low percentage of Black or African American licensed clinical staff, around 13%, compared to when you look at our penetration rates in terms of the number of Black or African American clients who access and engage in behavioral health services, there's around 20%. That's the penetration rate. So you could see there's already a disparity in a way that if you would try to make this more pragmatic, clients who identify as Black or African American find that our workforce that's not sufficiently and effectively really represent them or mirror their identity as Black or African American. We don't have enough Black or African American behavioral health providers in our system. Then based on that came all the countermeasures on how to really address it in terms of looking at our hiring, retention, and recruitment of more Black or African American therapists and also providers, and also other groups as well, because we also see the disparity with other race or ethnic groups. Also looking at how do we make our practices more culturally responsive or culturally congruent with the clients that we serve. Now, within CYF, what we did first is really look back and reflect on our data. So every year we have a quality review, a state quality review from Cal EQRO, wherein they provide us data around our penetration rates. And what we notice, looking at our behavioral health systems in general, our penetration rates are lowest for Asian American, and Pacific Islander clients and their families, followed by Latino, Latina, Latinx, or Latina, or Hispanic populations. And also, we find sometimes, depending on the year, sometimes there's also a low penetration rate for African American clients. And again, I'm not expecting you to read the entirety of it, but it's just like walking you through that journey in terms of how did we use data to help inform our practice improvement or quality improvement efforts. We also look at our data through time, longitudinally. Has our penetration rates remained the same or changed through time, depending on the race or ethnicity of the group that we are trying to look at? And we found that it's pretty consistent. Reviewed our data on penetration rates. When we started this effort back in 2016, we look at the data as far back as 2010, 2012, to really see that in terms of penetration rates, they have been consistently low for our Asian American or Asian and Pacific Islander clients, and also for our Latina, Latino, Latinx, Latina, or Hispanic like clients. So based on that, after really reflecting on our data around penetration rates, comes the question, what did our improvement project look like? How did we start our quality improvement project around this? So looking at the roadmap, we really wanted to anchor our quality improvement efforts around first looking at other data that would help us understand the root causes or explanations behind why penetrations are so low for certain populations. Again, going back to our A3, we looked at really, our problem statement really highlights the need to look at match, the racial and cultural match between our workforce and our clients, or looking at it on the individual level, really trying to address the question, do our clients who access or engage in our system find that the clinician, providers, or the programs that provide them services mirror who they are in terms of their racial or ethnic identity? And so we paved the way of truly understanding our data stories on access to and engagement in behavioral health services, specifically for the children and youth clients. And one thing to really encourage our system to really think through this is using a trauma-informed approach to clinical intervention. And most of the time, many clinicians or providers in our system think about approaching the work of working with clients who sometimes present with trauma as looking at it in terms of a metaphor, like an iceberg. Some clients come to us where we initially only see and hear about the tip of the iceberg, like the referral question. They were referred because of, a report from the teacher around like violence. They were reported, there's a referral report around like some anger outburst, within the playground or in the community, or acts of violence or defiance, or sometimes for youth or even like for children. Sometimes it's a crisis situation wherein that's the first time they enter our system. So it's a report around suicidality or causing harm to others. And what we may see is this host of behaviors that most of the time they are externalized behaviors. But that's only one part of the story. A trauma-informed approach to really looking at how a client presents with their story is to really think about what's underlying, what's underneath that tip of the iceberg. What may be the feelings, experiences of that particular client that is resulting or precipitating or even perpetuating those behaviors that we see within a client. It might be experiences of trauma. It might be racial trauma, especially for Black, Indigenous, people of color communities. It might be intergenerational transmission of trauma. It might be histories of depression within the family or other mental health presentations within the family. With this, we get to hear it more from a client once the therapeutic alliance or relationship with the client has truly been strengthened or improved through time. So using that approach around like a trauma-informed systems now leads us more to thinking about QI work. And a lot of QI tools talk about root cause analysis. Like when you have a main problem, how do you dig deeper in terms of what is the underlying story or the underlying root causes of that main problem? So we engaged our system in like focus groups and also data reflection circles, where we talked about, given this main problem that we have around low penetration rates, what might potentially be the stories that would really capture the root cause or the underlying story behind it. So we heard stories around racial or cultural match, that we don't have a workforce that truly mirrors the race or ethnic identity of our clients. And there's also, of course, especially working with Black, Indigenous, people of color communities, there is still a very strong mental health stigma around engaging or even accessing like mental health or behavioral health services. Also, we use other lean tools like the fishbone diagram. And this also talked about, is there some limitations around the measurements that we use? So for example, penetration rates are based on using a denominator of those who are medical eligible. And we found that there's some imperfections around using that metric, because really the reality is when you think about eligibility for state-funded insurance, it does not necessarily translate that those who are eligible also have equivalent needs around like mental health or behavioral health. So we thought that even that metric itself around penetration rates was really very limited in how it captures the way we talk about the story around like penetration. Also, in thinking about disaggregated data, given the diversity of the clients we serve, most of the metrics and data visualizations we have seen so far really lump a lot of race or ethnic groups in terms of global categories. And thinking about, for example, within the Latina, Latino, Latinx, Latine, or Hispanic communities, there is a very varied diaspora in terms of like thinking about different cultures from North America, South America, Central America. And that's not a lot, it's not captured a lot by a lot of our data. So really disaggregating data is really something that we found as necessary in terms of like thinking about this work. Also in terms of thinking about the services we provide specialty mental health service. And that often is contingent on the fact that there should be a medical necessity established, that the client is impaired enough in their behavioral health presentation for them to need treatment or specialty mental health. And really, really trying to, and that was part of our conversation to in terms of like underlying causes. Potentially, are there communities or do we have clients who don't really see that their path to recovery or healing needs intervention? Probably we could start really strengthening our prevention types of services. Probably it's not specialty mental health that they need. Probably they just need like a wellness program. Probably they need like system navigation to help them access services within the community to help them with basic needs. And that will help them eventually with their recovery, given like mental health presentations. And a very persistent theme that we saw too is really that question around or issue around racial or cultural match, that we don't have a sufficient number in our workforce or quantity in our workforce to really mirror comparatively, like really mirror the population that we serve in terms of their diversity around race or ethnicity. So going beyond that, again, following our racial equity data roadmap, we tried to think about, are there other data sources that we could leverage to really uncover the causes of these differences, to really capture that underlying story? And also, given like data, how do we present our data in ways that would really engage people to collaborate and really excite them about this collaborative work around action planning based on what we have reflected on around our data? So came that process of really reflecting on our cultural match or racial match data stories. Now, to ground us into the work, what we did in our team is really first to situate ourselves in the larger literature or evidence around like cultural or racial match. And most of the literature spoke about like Latina, Latino, Latinx, Latina Americans, or Hispanic Americans, and African Americans generally prefer to be matched. And that's mostly around when they first access services. They prefer that, like for a Black client, they prefer to see like a Black provider. On the other hand, when we think about more, how do the racial or cultural match really translate to outcomes? From many meta-analytic studies and systematic reviews, there is little evidence that therapeutic outcomes improve as a result of racial or ethnic matching. In fact, there is a strong decline over time in the benefits of ethnic or racial matching on client participation and engagement in treatment or services. And really what it's, the story that this is trying to bring forward is really about, it doesn't mean that racial or cultural matching is not important at all. It is most important, especially in the beginning of treatment or intervention, or when you're trying to get clients to really access services. It's very important for them to see that their racial or ethnic identity is really represented or mirrored in the services that they approach, in the workforce of programs that they approach. But through time, it's not enough to just have that racial or cultural match with your provider. There should be something else that would truly help the client lead to positive outcomes in healing or recovery in terms of their mental health presentations. So based on that, that was like our grounding way of really looking at the stories in the literature around racial or cultural match. And we tried to be aware and sensitive to this, the existence of this story in terms of how we talk about our data around racial or cultural matching. And I mentioned a while back, one initiative that we leverage in terms of this effort is really our data reflection initiative. And our data reflection initiative within our system of care started back in 2015. Because during that time, and it's a trauma-informed approach of truly approaching data in a storytelling way. Because most of the time prior to that, it was so hard to engage providers, especially behavioral health providers, to think about data. Most of the time when I approach them with data and ask them, what does this chart mean? What does this data mean about your clients? And I give them like outcome measures around their data. Most of the time, I am approached with this, deer in headlights. And it's hard for them to really think about, okay, do I need to do this? I'm just here to really serve my clients in a clinical way. And so really the aim of the data reflection initiative is to pivot more, to shift the paradigm into thinking more of data and communication and conversations around data as almost like, a talking circle or circle time, like with children, or, like group therapy, and we feel warm as we engage into the data. And really, this is very much like informed by the brain. Why storytelling? We know for a fact that, the areas of the brain that are activated and light up with within our neurons are pretty much limited when the brain receives data, facts, and anything logical. However, when the brain witnesses or hears a story or sees a story, many more parts of the brain are activated. And with that, that translates to more engagement for a particular individual. So leveraging that was part of our initiative around data reflection. So we have actually a website, and I could share the link to you in a little bit around data reflection. So we developed this website for us around practice tools that we use clinically, but also tools that we use in terms of really storytelling around our data outcomes. So we called it the Data Reflection Initiative, and me and my team conduct a lot of data reflection assist workshops on how we can tell stories about our data. And really, that's part of this roadmap of really how do you present data in ways that help people make sense of the numbers, but also really motivate them to engage better in terms of the data that they have around like outcomes. So I'll just share like a few things that we have leveraged in this effort. One is, using a storyboard approach. Many times when we present data, we often ask people, what does the chart mean? What does this mean when it's high here? What does the number 43 mean? We shifted the way we ask a question in terms of really asking providers, for example, in our system, what's the story here? Can you tell me, are there heroes, heroines, sheroes, theros? Are there villains in this story? What are the resolutions to the conflicts in the story? Is there a conflict in the story? How did the story begin or end? So for example, this was one clinic's data. They serve primarily Asian and Pacific Islander clients. And when I show them their data around their CANS, the CANS is a child and adolescent needs and strengths assessment. In our system of care, it's our outcomes tool. And within the clinic, so in the CANS, there are items there that talk about, for that specific item, how many clients in your clinic has that as a problem or as a need. So for example, anger control is the highest in terms of a need for that clinic, followed by impulsivity and hyperactivity, and so on and so forth. And when I ask the providers for that clinic to reflect on their data and ask them to really think about storytelling, like if there are metaphors that you would like to adopt to talk about the story, what metaphors would you use? And they came up with something like, oh, this is the story about like dragons. This is a group of dragons and they go to school and they are very angry dragons, full of impulsivity and hyperactivity, breathing fire everywhere to everybody they meet in their way, trying to destroy everything. Then later on, what happens to that dragon as you become closer to them, they tell you more really why they are so angry. They tell you stories about how difficult it is to be at home because they see their parents fighting all the time. They are in their communities where they witness violence all the time. And it's so hard to really contain that anger, and they can't help but really breathe fire all over because that's their way of really expressing their anger. So that's one story shared by this clinic. And really that captures metaphorically what they're trying to tell me in terms of the story of that clinic. Most of their clients, when they first enter treatment, they are very angry kids and youth. They're full of anger, not only towards others, but also towards themselves. Very impulsive, very, very hyperactive. But really, in terms of the trauma-informed approach, it's the tip of the iceberg. The underlying story behind that anger is a lot of trauma in the community, but also trauma in their homes that these children and youth experience. That is truly the underlying story behind their anger presentation. So in their data, adjustment to trauma is not captured more widely because that comes later in time. Once the therapeutic alliance becomes closer or stronger between the clinician and the client. So it comes through time in terms of like the work. At the same time, this use of storytelling is also anti-racist in a way that we look at anti-racist practices because a lot of indigenous communities tend to use like storytelling, and it's central to their lives in terms of how they make sense of their experiences. Like with Spanish-speaking communities, they talk a lot about like folklores or like folk tales. And this is true as well for many different cultures. Stories that are expressed in terms of songs or poems. And within our clinics, they culturally adapt certain practices by really capitalizing on like stories. So for example, there is this culturally adapted cognitive behavioral therapy model called cuento therapy, wherein you use folk tales for Spanish-speaking clients, use folk tales that originate from like Mexico or South America as a way to use tools around helping the client challenge their maladaptive thoughts. And that's the essence, for example, of cognitive behavior therapy. But using a culturally adapted methodology of really storytelling, or using stories or cuentos in Spanish. So that's one way. Or for example, in storytelling, like in Native American cultures, they talk about talking circles. And really for us, data analytic reflections became like storytelling circles, wherein sometimes there's a talking stick that we use adopted from Native American cultures to go around sharing the story around what this story around this data really speaks to and aligns with stories you have around your clients. I work with the children's system, and something that we were also attuned to is that how could we leverage clinical practices in our data analytic work? So for example, many of our clinicians use SAN trace in working with kids. And in the SAN tray, kids and even youth, and sometimes with parents as well, they use the SAN tray as a way to tell stories by using miniatures to tell the story in a nonverbal way, especially if a client has trauma experiences that it's hard for them to truly verbalize their experience. But then they can tell their story in the sand in a nonverbal expressive arts way. And really like using things like that, we use that as well, like in data, we adopted like a data sand tray processing of asking questions instead of asking like, what are the numbers? Like what's happening in your story around this chart? Is there energy in the story? Where is the energy? And the use of energy, for example, is a prompt we often use in talking about sand tray stories with our clients. Like, where's the energy here? Where's the power in your particular sand tray story? We use that, again, in a parallel process way to also ask the same types of questions when our providers or our system are engaging in data reflection around their outcomes data. Now going back now to racial or cultural match. So this is an example of a chart, a data story from our civil service programs. We have about 8 in our system. Most of our programs are CBOs that are contracted with the city, but we have our civil service programs where we piloted this effort of really looking at race or ethnicity match between clients and their clinicians. And what we found is the race or ethnicity mismatch story is really most likely with Latina, Latino, Latinx, or Latina clients. As you could see here, the teal really represents the proportion of our clients. So we serve mostly Latina, Latino, Latinx, or Latina clients, followed by Asian in this one, but this is for our civil service programs only, and then followed by Black or African American. However, the green one, the light green bar in the chart, tells you the story of the proportion of our workforce. But this is based on FTEs or full-time employees. Also realizing that we had to use FTE because it tells a better story, because some of our providers only work in clinics for half of the time, like 50% of the time, some 30% of the time. Like when we think about psychiatrists who move around like programs, sometimes they have limited time, only a proportion of their time providing services for a particular program. So we use FTEs. And with that, we capture the story more in terms of looking at this racial or cultural mismatch. As you could glean from the story, it seems that our racial or cultural match so far, there's a match if we think about our Asian clients and also our Black or African American clients. But this one, through data reflection, we truly really unfolded the real story. Although it seems based on these numbers, oh, we don't have a problem. It seems our workforce have enough Black or African American providers. But the reality is this one was really based on the workforce itself. So it includes all the staff within a clinic, from the administrative staff, from supervisors, from the managers, and the providers of mental health services. However, for most clients, they still talk about, we don't find enough, for example, Black therapists who are male, which was one that was really named in terms of the need in the community to serve a Black male youth. And so there's that need. But we found it important to include the entire workforce in doing this data matching, because again, we think about the approach to work in terms of more a community-centered approach to work, wherein as you enter the community or the program, what do you see? Is your race or ethnic identity mirrored by what you see from the administrative staff that you first interface with, from the staff who go around that clinic, from your case manager, the social worker, the psychiatrist, or many other providers in that particular clinic? So it was important to capture the entire workforce. Now with Latina, Latino, or Latinx or Latina, that's where we found the greatest mismatch in terms of Black story. And going back to our roadmap, are there other sources of data? Again, part of this data roadmap talks about aggregated versus disaggregated data. We might see, for example, here, oh, we don't have a problem in terms of racial or cultural match for Asian identified clients. But the reality is, if we disaggregate the data, and that's part of our improvement project to look at disaggregated data for each global race or ethnic category, for the Asian sub-ethnicities, we found that there is a disparity when we think about our clients who identify as Chinese. And part of that as well is some limitations around language, especially like for many families that we serve, they might have monolingual Chinese-speaking caregivers. And so if you're thinking about doing family therapy, it becomes more difficult to really engage them in family therapy work if we don't have enough in our workforce to serve that family. So as you could see here, there's no disparity or need around like racial or cultural matching for Filipino clients or even for Vietnamese clients. And these are our top 3 in our system. However, for our Chinese community or our Chinese population, there is a disparity. We have more clients, the proportion is higher, but not enough proportion representation in our workforce who are Chinese, or who identify as Chinese or are Chinese speaking as well. So at the same time, we also want to think of stories as something longitudinal. Are we improving in our efforts across time? So of course, part of this is across time, we have to really strengthen our efforts around like hiring and retention of our workforce so that they are more diverse in their representation. And longitudinally, this might not be the best storytelling visualization around it, but in here in this particular chart, going into the middle is ideal. That means the proportion of your clients and the workforce are pretty much the same. So there seems to be no problem there in terms of racial or cultural matching. So the vision is for all these lines to approach the middle. But as you notice here, across 3 years for the Latina, Latino, Latinx, or Latina populations, it improved from 2016 to 2018, the racial or cultural matching. However, it dropped again during the time of the pandemic, which is 19 to 20. And then for the Black or African American, it went from here, close to ideal, it dropped, and then it went back close to the ideal. However, that's when we recognize or realize after data reflection efforts and really talking to our community around it that, yes, that is true if we think about our workforce, but still in terms of actual direct providers of services, mental health providers, we don't have enough in our workforce who identify as Black or African American. And you could see there, of course, there's an overrepresentation of like white clinicians or providers in our system. So it's not a problem for them in terms of racial or cultural matching. So that's part of our story, also looking at it longitudinally. Now, using other data sources as well and thinking about what can further help in terms of us thinking about this racial or cultural match is to go beyond the limitations of quantitative data. So I mentioned about our CINs, our Child, Adolescent Needs and Strengths Assessment. That's our outcomes measure, which is actually mandated by the state. So every client who enters our system that receives specialty mental health services has to be administered the CINs by a clinician. There is one item in the CINs that talks about cultural stress. Now, our CINs is also integrated in our general assessment. So there are parts of our CINs wherein clinicians are prompted to write a narrative around certain items. So at least we really can find out the story behind a rating of that particular item. So in our cultural stress item, we actually tried to, again, part of our improvement effort is to try to really see for a client, if they are stressed by their culture or diversity, what's the source of that stress based on their identity? Is it based on their race or ethnicity, sexual orientation, gender identity, religion, language, and all other levels of diversity based as informed by the addressing framework of Pamela Hayes? And for clinicians or providers in the system, they are able to check that, like what's the source of the stress of your client around culture. But at the same time, they're able to write a narrative. So that is part of our data analytic investigation. It's also to look at qualitative stories. Of course, it's more challenging in terms of really looking at like themes. We did some form of thematic coding of some responses that we heard from providers and how they describe cultural stress among their clients, and some form of grounded theory approach as well. But again, it's very rudimentary not in a way that really aligns with how it should be done, because we have so much data and we have limited people in our team who are able to engage in this. But a lot of the stories here really capture what's needed for us to improve our work around cultural or racial matchings. For example, here's a story of the client is an African-American preteen male. The client has expressed his anxiety, fear, and anger of the current social and political climate of racism. The client is seeking an understanding of why someone could hate another solely on the color of his skin. The client asks the clinician, who identifies as a cis white middle-class male, why white people hate Black people. Client expresses sadness as well over the death of George Floyd and the trauma of watching it on social media. This clinician is exploring ways of responding to this through supervision and consultation with colleagues. Here's another story. The therapist is of a different racial or ethnic background, Caucasian and Hispanic, and has had a different cultural experience and socioeconomic background than the client and her family. At this time, the teen client, who self-identifies as Peruvian, and her mother have not expressed any concerns over this cultural difference or reasons to believe it will interfere with client's progress in treatment. So based on the stories, through some preliminary thematic coding, we found a couple of themes that could really be highlighted. One of them is that there's a difficulty across many providers of really responding to or intervening with experiences of racism among Black, Indigenous people of color clients, especially if they bring it up in therapy. There is limited competence in truly being able to address that or respond to it. Also, there seems to be a persistent story around waiting for the clients to start the conversation. Even if it's clear, in entering the room with a clinician, that there is a power differential or there is a difference in terms of race or ethnic identity, most of the time clinicians wait for the clients to bring that up or express whether they have concerns around that difference in terms of race or ethnicity. So we use that in terms of really thinking through how could we shift our practices to really address this racial or cultural match. Part of it is we also knew that there is little evidence that therapeutic outcomes improve as a result of racial or ethnic matching. Now, we don't want to really think that that is true across the board, because most of this evidence was based on aggregated data, but not disaggregated data. So part of it is we try to investigate this further within our system of whether this is true using our CINs. And this is just one example. The story here is really, this is specific to a chart from our clients who present or who identify as Latina, Latino, Latinx, or Latina. And the orange bar is really the proportion of clients who improve in a certain domain in the CINs, whether it's risk, traumatic stress symptoms, and in the blue is the proportion of clients who improve on that particular domain. So the blue is for those who match with their clinician or provider. The orange is for those, the blue is for those who are mismatched with their provider, and the orange is the one, is the proportion of improvement for those that are matched with their provider or clinician. So you could see there, it's quite stark in terms of the story that across many domains in our CINs, clients improve more if they are matched with their clinician in terms of like race or ethnic identity. And so the next step for that is, how do we leverage all that to plan or act on differences and to move that data to action? So moving from data storytelling to action planning entails developing, for example, SMARTY goals. SMARTY goals going beyond just the SMART goals, but including like opportunities to think through goals that are inclusive and equitable. And also looking at how do we pilot PDSA or small tests of change within our clinics, and making sure we use like a race equity lens. And part of our journey around this is practice improvement steps. I will just outline like a few of them. What steps did we take as a system to improve our practice, leveraging what we know around the storytelling around racial or ethnic cultural matching? Simultaneously, I will speak more to clinical practice improvement efforts, but also know that within our BHS Race Equity Council, they're also looking at improvement projects that are related to hiring, recruitment, and retention of our providers in our workforce, to narrow that racial or cultural mismatch, especially for Latina, Latino, Latinx, or Latine, and Black or African American clients. So from clinical practice improvement, our steps, I will just mention a couple of them. We looked at the evidence of our practices first, like really looking at what interventions do we routinely use with our clients, and are they culturally adapted? So we had a dashboard, and I could share the link of the dashboard later on so you could explore it. Just really finding out what therapies or specialty interventions or evidence-based practices are being used in our system across different programs. And what we found, most of them are cognitive behavior therapy, and a lot of this were really, the established evidence around them were based on Western and also white populations, white middle-class populations. And there's not enough cultural adaptations around them. So a main criteria for improvement project was really looking at how do we culturally adapt these different interventions? Even though they're already being used in our system, how do we provide trainings and also resources to our system around how they could really culturally adapt different practices? At the same time, in working with clients, even though you are mismatched with your clients in terms of race or ethnicity, how do you hold conversations around that difference with your clients? So part of our race equity plan are trainings within our system around racism and how to start those conversations with your clients. We leverage trainings from Dr. Ken Hardy and also Dr. Anastasia Kim around the Kim constructive conversations model. Now with that model, it gives providers like steps, like how do you open that conversation with your client? How do you start that conversation? Like in terms of, if you notice, we both differ in this room in terms of our racial or ethnic background. How does that impact you? What does it mean to you that we are different in terms of that? So conversations like that, we started to have those trainings in our system to truly help our clinicians and providers in terms of having those race equity constructive conversations with their clients. At the same time, we also thought about our trainings in terms of, are there cultural adaptations that we could use for our different practices? But also thinking about, are there models of treatment that have been, that are community-centered, but also their evidence is based on certain groups that are Black, Indigenous, or people of color communities. And also we thought about our civil service programs. Do we have programs that have initiatives already in place that serve specific groups? So for example, in our civil service clinics, we have one program called Coamba Healing Project, and their aim is really around system navigation and providing prevention work, primarily targeting the Black or African American community. And based on that, then within our system, we found ways to help support them better, and disseminate, of course, their implementation of their practices as well across our system. So that's also something that we are working on. Also, again, in terms of resources, we tried to establish our own website, whereby it became for us like our way of communicating different practices within this race equity lens to really encourage clinicians that whether matched or mismatched with your clients, what are ways by which you could really strengthen your cultural competence or cultural responsiveness by really being more active, like carrying a deliberate practice of culturally adapting or modifying your interventions so they fit the uniqueness of your clients, especially in terms of their race or diversity. Yeah. And then also in terms of like data, again, going back to the data analytics, we also thought about Heritage Months. We use this as an opportunity in our system to really think about, okay, let's do our data storytelling specific to certain groups around Heritage Month celebrations. And based on that, use that as an opportunity to talk about what are our outcomes so far, or data analytics so far, stories that are specific to that group, and what can we do to help address what we realize from those data analytic tools. I will end my presentation with what we have learned. And this is just very brief. We have learned through this, there are both strengths and needs in terms of our practice improvement efforts. Connecting QI efforts with our system values was really an opportunity for us to strengthen the work, but also leverage already what we have so that our providers could be more engaged in it. So anchoring our QI work in trauma-informed systems made it easier for a lot of our providers to engage in QI work, just because it's already trauma-informed and it's a language that they already speak in their clinical interventions. And we try to align many of our practice improvement efforts with our larger racial equity or equity department to make sure once they have an A3, how do we address their countermeasures within our division? Also attunement to anti-racist practices. So this is something too that we are strengthening our system as a way to address racial or cultural ethnic match gaps that we find in our system. But in terms of needs, again, this is where we stumble. Data is not easy to find because most data that we have, for example, is aggregated, and data around self-identity could be very messy. So it's a lot around really finding ways to streamline the process of collecting data around self-identification are some things that we try to strengthen in our system. Also, the limitations of like quantitative data, because really if we're moving towards storytelling, a lot more stories could be gathered and leveraged from qualitative stories from clients, but they are more difficult to really analyze, especially if you need a manpower, person power to really think through, grounded theory approaches or like thematic coding. Also, the context of COVID-19, what I realized within the past year, because of the burnout experience in our system in trying to really help a lot of our clients, there's less bandwidth in really engaging in QI works. In a lot of ways, this slowed down for us, like in the past year. In terms of key takeaways, I think it's very important, especially if you have new practice improvement projects that are related to QI, to think through what are you anchoring them with in terms of the system values that are already existent. Because if you do that, you could encourage more engagement like in your system if they are anchored on already system values that are existent. At the same time, often us also being aware of the difference between adaptation, like you adopt a model versus adapting a model, versus really trying to find opportunities for homegrown methods of really conducting like QI work, because that could be part of the spectrum by which we could conduct like our QI work. So I would end there. Sorry, I went over in terms of my time, but I just wanted to offer like a few minutes opportunity for questions, thoughts, or reflections just based on that presentation. Thank you so much.
Thank you so much, Dr. Rubio, for sharing your work. And it's just really impressive all that you have been doing within this program and other work across the department and your division. I will look out for more questions from the group. Please add them into the chat as you have them, and we'll call on you as we have done with previous sessions. But I have a question for you, which is, we've had a lot of conversations over the last day around, data and how to collect it and how to use it. And even this morning with Dr. Webb, he talked about the importance of using data to tell stories, similar to what you have shared now. And we've also talked about how it can be challenging to collect the right level of data or the right kind of data. So curious if you can share some advice with those on the call around if they're not collecting the right data or they're not getting the right data from those that they partner with, what do they do and how do they then tell their story or effectively integrate health equity into their programs and initiatives?
Thanks, Maria, and that's a great question. I think initially you have to have almost like a reflection first of your landscape. Because if data is not being routinely or consistently collected yet, I know like many programs, you go through audit cycles, especially if you are funded. And there are opportunities there for really collecting data. But start first with really anchoring your work in terms of what data do we have already that we could leverage? And sometimes that data could be messy, but it's a good start. Sometimes that data could be limited. Sometimes you'll find out, oh my gosh, we only have like 3 data points. How are we going to tell a story about that? And for me, I don't see that as a limitation. 3 data stories are 3 lives that you could change, and it could ripple effect in terms of your practice improvement efforts in your system. It could be a good start. And sometimes with 3 data points, what's the story that is being told in there? Sometimes I've done QI work wherein, because of the complexity of collecting the data, we would just do like a case study of like 1 or 2 cases. Talk to those families and clients, get the full story of what's going on, how did they navigate an entire system. And what I find was, even with those 2 stories, it can help create a whole infrastructure of practice improvement, because those stories in itself really represents many other stories that are shared within the system. Yeah. And later on, once you have somewhere to begin with, then you move towards what are your data needs? What can we do better? And again, do PDSAs. Where can we start with? Let's pilot it with a small program. Let's start with 3 data points to collect first. If it's something to do with racial or ethnic matching, for us at first, it was about how do we structure or streamline our self-identity labels so they are consistent between our workforce and our clients. Because what we found when we were first doing this data, the identification categories for our workforce were almost completely different from the one we collect for our client. So it was hard to match them. It was really hard to match them without having some preliminary way of really just trying to, okay, let's just assume that this person who identifies as Peruvian would also identify as Latina or Latino. Let's just put them there, but you're not sure. Because again, that's a problem with the way you collected it. So for us then, in terms of beginning to structure a way of collecting that data, we started there. It's just one question and then creating like categories out of it. It might seem like a simple project, but then it was so hard to collect. So I guess for me, what I'm trying to say is start somewhere, even though it seems that, okay, with just one question, and you would realize from there, what are your stumbles along the way? What can we do to strengthen it further? And then later on in a graded fashion, let's add more. What are other data points that we could add in terms of that?
Great, thank you so much. So I'll pass it off to Catherine, and just as a reminder, if you can just introduce yourself and where you are, that'll help Dr. Rubio.
Sure. Catherine Phillips, California Healthcare Foundation. First, thank you. Tremendous presentation. I have to say I'm blown away by the data you have and how intentional and thoughtful you've been about using it. I assume that takes a lot of resource, a lot of time, and a lot of expertise. And so I'm curious to for you to reflect on sort of the leadership that's allowed that to happen, that allows you and your organization to devote those resources, to get that expertise, to make this a priority, and sort of what advice you would have to our group, particularly those who are just starting off on this sort of data and equity journey, about how to ask for the right things, get the attention, and get something like this moving in usually very resource constrained environments. So how you did it and sort of your top tips for others.
Thank you, Catherine. Also appreciate your feedback around the presentation. And I think one tip I would give is really thinking about that system of like anchoring. Like when you think about change, most people are resistant to change if it is something completely different, like you are trying to shift like an entire culture or an entire paradigm. I think as a good start is really a way to start is really to be observant first of your organization. Like what are current practice improvement plans that are being used in your organization? What are their priorities? And then based on that, thinking about quality improvement efforts with a race equity lens, what are projects that you could start that sort of supplement or can complement or support any of those goals within your organization? I'll mention something, like for example, in our primary care clinics, a lot of their efforts sometimes are guided by True North metrics. And sometimes they would choose like, okay, what True North metric are we trying to emphasize here? For example, like safety. So if I'm going to collaborate with them or create like a practice improvement project, I may think of a project first that is aligned with safety as a start with. And with that, then I could get their participation, I could get stakeholders to support the work even better. I could get funding for it, because it's aligned for that. And I should demonstrate that if I do this project, it would help answer your problem goals around that particular goal that you have around like safety. Mm-hmm. And then later on, once they trust you in terms of that collaborative work, again, it's a very graded way. Then you could introduce in the next year another project, still related, but sometimes it could already have a feel of like something new that is coming to the work to help something that you are envisioning as a new goal, for example, that could be around like race equity. So for me, I feel that starting something new, it takes a lot of energy. And I've done also projects like that. Not to say that I haven't done projects like that. But if I really wanted more support, for example, from leadership or from BHS, for example, with our executive team, I look at, for example, I mentioned it in the presentation, what was the A3 for that particular organization? Instead of me creating my own A3, coming up with my own goals, what's already existing? And then I tie it with that. Yeah. I hope that helps in some way.
Mm-hmm. Thank you.
Great, thank you. Sitar.
Hi, thanks. Sitar Testo, Manager for Health Ed and Pop Health over at Health Plan of San Joaquin. Thank you so much, Dr. Rubio. That was an amazing presentation. I really appreciate your emphasis on storytelling. I think that's one thing that we definitely don't do a great job of. And I think the time that you spent on the importance of storytelling is really going to help us kind of create more value in that as well. But my question was around matching SOGI data, if that's something that you and the team looked at or considered, especially around discussions for behavioral health and mental health, and whether or not maybe your clients have ever requested, being matched with someone based off of their own, orientation.
Yes, thank you for that. That's an important question. Also realizing something I haven't named is also the limitation of really focusing on racial or cultural match. We start somewhere, but also knowing that when you think of like clients, most people have integrated self-identities, wherein depending on the level of diversity, you identify differently, in terms of gender, race or ethnicity, sexual orientation, and many other levels. Definitely, it's something that we have thought about. However, just to acknowledge the limitation in our system, like working with children and youth, we haven't yet created like best practices or guidelines in terms of really asking questions around SOGI from our clients. And part of that is really issues around confidentiality and privacy, because for children and youth, the owners of their electronic health record and who has access to it are most of the time their caregivers or their parents. And sometimes we meet with children or youth who are not ready yet to come out to their caregivers or their parents. So that makes it very difficult for us to truly find or collect data around like SOGI identification. However, for our adult system, that's a project that they are beginning to look at in terms of match based on like SOGI identity and trying to find out, I think it's a project created by our Gender Health SF, which is our division in our department that are specific to working with gender expansive youth and also like adults. So it's also something that they are working on. Thank you for that question though. But again, as a way to also continue with that conversation, again, match should not only be in terms of race or ethnicity. Like ideally, you would want to think about also other levels of diversity.
Great, thank you. Dr. Rubio, I just want to check in. We're, at that 10 minutes over 2 o'clock mark. We have 2 more people who have questions. Do you have time for that?
Yes, definitely.
Okay,
of course.
Perfect, great. So Sophie, I'll pass it off to you next.
Thank you. I'm Sophie Bergqvist from Center for Care Innovations. Wonder if you have seen any research where matching has been done with not the specialists, but the first point of contact. If there's been any task shifting for behavioral health services and recognizing that there's such a supply-demand gap with specialists to do matching well. So any thoughts? And then one observation where I thought that with virtual care, we would see an increase in matching just because you can find someone. And I haven't seen that. And if you have any reflections on that.
Thanks for that question, Sophie. That's a very important question. I know there are, but it's something that I haven't really delved into. Because again, like looking at that limitation of the literature around, when you think of racial or ethnic matching, it's most important at that point of access. So I have seen some, but I haven't really collected them or collated them. Because again, like realizing the first point of contact is important for that. So in our clinics, we do our own QI efforts around it based on qualitative research. That knowing that sometimes for a client to go to their first appointment, sometimes it depends on who did they talk to first, like in the clinic. And that's very important. Like who's the administrative assistant who called them to remind them about their appointment. And if they felt that even without phone call, oh, this is a clinic that welcomes who I am based on my race or ethnicity. And that person probably shares my race and it encourages them more to access or engage in that service. Yeah, and it's an important question, but definitely something I would put in my radar, to look more for more literature around it, because it's a great point of looking at in terms of the research.
Great. And last is Sunita.
Thank you so much, Marie. Dr. Rubio, that was phenomenal. I love that you wove in storytelling and MRIs and change management into one talk. It's really impressive. My question for you, because you have this expertise, is maybe, and that Catherine asked the question that I was sort of intending. So what I'd love to pick your brain about is not everyone lives in an area where we have access to be able to do matching at the level that even you've been able to do, which, you know, again, we have shortages there. But what guidance would you give if we are in an area where matching doesn't seem possible, and yes, measurement around it should be? What can we do, and what should we be monitoring in that setting for looking at quality?
That's a great question. And I'm trying to think about if you cannot have access to the data to really have a systems level way of approaching like practice improvement, what could be done? I think for me, if you think about it, you know, like using like lean tools, for example, like a PDSA, is there a way to do like a PDSA project wherein you just find out, even with like a few providers, like it could be like 2 or 3 as a start, like having them, you know, talk to clients that they interface with. And part of probably like a satisfaction survey at the end is asking a question that is related to racial or ethnic matching. Like, how was it for you to meet with me, knowing that we are not matched in terms of race or ethnicity? And just get like a qualitative data around it. It could be like very conversational in a storytelling fashion. And with that, I think that could help a program truly understand whether that match has an impact and what's the impact, whether it's pleasant or unpleasant for, you know, clients that they serve within that particular clinic. I think I would start with that, especially if there's no access to the data. But I would still encourage that down the line, especially if you see that the match potentially has a negative impact, if there is a mismatch in the system, to have really a more rigorous way of collecting that data and creating that infrastructure. Because I think having data like that is very important in thinking about what structures do you want to put in place in terms of really creating a workforce that mirrors your clients. Part of that is working with HR, for example. And sometimes in working with HR, having data sometimes could really move mountains in terms of really, oh, okay, we have to really look at how do we advertise our jobs? Do we advertise our jobs in certain communities so that we get members in our workforce who come from those communities, you know, things like that.
Thank you so much.
I hope that helps.
Yes, thank you.
Great, thank you so much. And thank you so much, Dr. Rubio, for sharing your work with us. So hopefully everyone on the call can join me in thanking you for all of your great work and for sharing with us. Really